Well, hello and welcome to this month's podcast, where, as always, we're going to bring you up to date with the latest information and data in the wonderful world of rheumatoid arthritis. Now, in today's podcast, we'll be reviewing papers by Judith Hoyts and Carolina Longova, in which we discuss subgroups of patients with early RA with or without biologic DMARDs who achieve sustained DMARD-free remission and barriers to the widespread adoption of CAR T-cell therapy in rheumatic disease. So pretty topical and I think quite interesting, to be perfectly honest with you. If you want to access detailed summary slides to the papers I'm discussing today, please visit iMedForum.com. iMedForum, all one word, .com. Alrighty, so let's dive without further ado into paper one, which is the sustained DMARD-free remission in subgroups of patients with rheumatoid arthritis, and this is an analysis of two prospective cohorts with early arthritis. Well, let's get the background into our minds. About 20% of people with rheumatoid arthritis on DMARDs achieve sustained DMARD-free remission. And 2022 EULAR guidelines advise against complete DMARD cessation due to the risk of flare. It's thought that the subgroup of patients who require biologic DMARDs are less likely to attain sustained DMARD cessation than patients who never need a biologic DMARD. It's kind of intuitive, they were milder to start with. So this study compared subgroups of patients with early RA with or without biologic DMARD use who achieved DMARD-free remission over several years in two study populations. So what are the key results? Well, eligible patients with RA who fulfilled the 1987 ACR criteria, the 2010 ACR EULAR criteria, or both from the Leiden Early Arthritis Clinic and T-REACH trials were included. EAC is a prospective population-based inception cohort consisting of patients with recent onset arthritis and symptom duration of 2 years or less at the time of inclusion. T-REACH, on the other hand, is a multi-centered stratified single-blinded trial. All patients with RA who were treated with a DMARD or oral glucocorticoids were included in this study. Patients who used biologic DMARDs were generally younger, had more active disease, worse HAQ disability index scores, and higher ESR rates compared with those who did not use biologic DMARDs. Now, in the early arthritis cohort population, none of the patients that used a biologic DMARD during 5 years of follow-up reached sustained DMARD-free remission. On the contrary, for patients who never used a biologic DMARD, the risk of sustained DMARD-free remission was 37%. In the T-REACH population, none of the patients that used a biological DMARD during 3 years of follow-up reached sustained DMARD-free remission, whereas 15% of patients that never used a biologic DMARD reached sustained DMARD-free remission. In the EAC population, anti-citrullinated protein antibody negative patients without biologic DMARD use had a 56% chance of achieving sustained DMARD-free remission after 5 years, compared with 14% for ACPA positive patients. And again, in the T-REACH population, the risk of sustained DMARD-free remission after 3 years was 20% in ACPA negative patients without biologic DMARD use and 11% for ACPA positive patients without a biologic DMARD use history. Okay, well, what do we make of this? Well, sustained DMARD-free remission is unlikely for patients with early RA who have severe disease requiring biologic DMARDs. Patients with early RA who do not require biologic DMARDs have a substantially higher likelihood of achieving sustained DMARD-free remission, particularly if they're ACPA negative. Now, I think that's really, really interesting. What diagnosis do people have who are ACPA negative and have disease that doesn't actually require biologic therapeutic and who, in large, at least significant proportion, will progress to being drug-free and apparently in remission? Well, I think that's an open question and is one of the major issues of our time to understand what is ACPA negative disease. Anyway, back to this particular manuscript, the current EULAR recommendations on DMARD cessation may suffer from an ascertainment bias, as they're based on studies that do not fully represent the entire RA population. And I think future guidelines for DMARD cessation should be revised to address the differences in remission likelihood between subgroups of RA patients. These evidences, of course, will come into the remit of the next EULAR task force who will be looking at this, and I guess we'll see how they go with that data set. Okay, well, let me turn now to CAR T therapy. Pretty much everywhere you go at the moment, you see commentary, blogs, papers, and discussion of the role, potential role, or otherwise of CAR T cell therapeutics in the world of rheumatology. These are therapeutics that are being explored now across quite a range of disease indications, but equally there are challenges that might arise in adopting CAR T therapy for rheumatic diseases. For example, adverse events, cytokine release syndrome, infection risks, high costs, and so on. Now, this paper, I have to say up front, acknowledges that CAR T therapy has benefits for patients with autoimmune disease, but looks to temper expectations by examining potential barriers. Now, what are the key remarks that they make? Well, first of all, CAR T cell therapy involves isolating and genetically engineering autologous CD3 T cells to target antigen-experienced B cells, offering potential for treating autoimmune diseases driven by pathologic autoantibody production. In other words, if you've got autoantibodies, if they are directly disease-causing in terms of the pathology, and you get rid of them, well, presumably the disease is going to improve. Now, autoimmune disease differ from malignancies in that they do not progress predictably. Malignancies are often identified before significant organ damage occurs, while untreated malignancies inevitably lead to increased morbidity and, unfortunately, fatal outcomes. So eligible patients may be limited in the field of autoimmunity, as many have non-severe disease and already have effective treatment options, or severe disease with poor tolerance for CAR T-related adverse effects. Now, many patients with rheumatic diseases have a favourable prognosis after their initial flare. And again, this is a group one would imagine would reduce the need for aggressive therapies like a CAR T-cell intervention. The authors argue that research is needed to identify patients likely to experience severe disease progression despite conventional therapy. And those, of course, would be people who may benefit most from CAR T-cell therapy. They comment also on rituximab-mediated B-cell depletion, which has been more effective in RA and ANCA-associated vasculitis compared with, for example, lupus, myositis, and systemic sclerosis. However, in RA, we have multiple other effective therapeutics. And a lot of this, I think, comes down to the depth of B-cell depletion. CAR T-cell therapy offers more complete and sustained B-cell depletion compared with monoclonal antibodies such as rituximab. And it does this not least by targeting tissue-resident class-switched B cells. Now, multi-week hospitalization and associated risks with CAR T may deter patients despite its potential for higher efficacy. Therefore, patients may opt for less intensive therapies that require less upfront commitment. Remember, although we see the disease in its continuity, they see the disease as a new challenge in their lives. It takes a lot to get your head around that. The cost and safety profile of CAR T-cell therapy is an additional and, I'm afraid, necessary barrier for discussion. Cytoreductive conditioning, cytokine release syndrome, immunologic risks, unexpected adverse events, long-term infection risks due to unpredictable B-cell depletion, and the actual numerical cost of $500,000 or potentially more or less per patient, all, I think, serve at the very least to focus the mind. So the authors conclude that the applicability of CAR T-cell therapy for rheumatic diseases may be limited to some extent, as B-cell depletion alone may not suffice for many conditions. The high costs and currently registered clinical trials may be insufficient to validate regulatory approval. They argue that safety concerns, including particularly cytokine release syndrome, require further investigation, and future efforts should focus on developing CAR T-cell therapeutic approaches with improved selectivity and safety profiles. Well, it's hard to argue with all of these conclusions, but my own thoughts, well, these are, of course, high costs, but if you got into a younger patient with a systemic tissue damaging autoimmune disease, potentially the lifetime benefits of prevention of damage could become really quite substantial. So I think there's some new thinking required here in the health economic spectrum. I'd also point out that the adverse event profile is a work in progress, and it's critical that we understand what adverse events are most likely to occur in our patients with autoimmune disease. The next few months and years, I think, will go a long way towards informing us of what we can really expect of this as a therapeutic modality. And as to building on CAR T-cell approaches, well, the bispecific engagers that are now being extensively trialed may be one route forward, or perhaps different cassettes in which CAR T cells can be made to be even more selective and specific in what they target offers some exciting potential. It's too early to say yes or no for this therapeutic. It's really exciting. The potential is remarkable, but we have a lot to learn. And I think we should now be in a period of contemplation, a period of reflection as we gather the data that will properly inform where this therapeutic will land in the end. Well, look, that's all I've got to say in this podcast. To view the full publications uploaded this month and to access our other podcasts and resources, head over to imedforum.com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you don't miss our podcast in future. That would never do now, would it? And as always, make sure to let us know what you think by leaving a review. And above all, thanks for your attention. I truly hope that this podcast and the whole IMED forum is helpful to you in guiding the decisions you make to treat those people that matter most of all, our patients. Thanks ever so much.